This is Introduction to Child Health and Pediatric Nursing from Kyle and Carmen's textbook, Essentials of Pediatric Nursing. So let's start with defining health. Historically, we just thought it was the absence of disease, and we measured it by mortality and morbidity. And I have those highlighted just to make sure you know those words. Mortality is what people die from. Morbidity is what they get sick from. We have really changed that definition, and there's been a shift, and now we look more at disease prevention, health promotion, and overall wellness. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So I think in the past we just made this continuum that you fell somewhere between health and illness. And now it's much more of a scatter plot, because you may have something wrong with you, some kind of a disease process, but you're managing it really well. So even though you're high on the disease state, because you're high on the appropriate management, your overall health is good. And then in nursing, we say people are not just biologic functions. They're a bio-psychosocial, emotional, spiritual being. So really, you have a point for each of those. So now we'd say health is more of a scatter plot and not just that single continuum. Because you can be in the hospital and have a pizza party with your best friend. So history of child health and child health care. Really in the late 18th century, so that means the late 1700s, children were considered a commodity or a property. They were valued, but to increase the population and to have workers. If you had a farm, you needed all your children to help you do the work. And you needed them to live long enough to take care of you because there was no Social Security. And with high child mortality rates, you had to have quite a few children to have any to take care of you. So that is not the view of children in childhood. So what changed? Well, towards the end of the 19th century, we started to really understand illness and pathogens. And with that, we were able to do things like pasteurize milk and create vaccines. The first one was smallpox, which has since been eradicated from the world. And we developed pediatrics as a specialty within medicine. And Dr. Abram Jacobi is always considered the first pediatrician. As time went on, the 19th and early 20th centuries, urban public health really improved because they started to improve sanitation, make sewerage systems, treat drinking water, and become aware of hygiene practices. Public health departments that really promoted public health developed, and people gained an understanding of nutrition, sanitation, bacteriology, and pharmacology that made huge differences. As we've gotten into the modern age, towards the end of the 20th century, we've developed lots of new antibiotics, vaccines for many different illnesses. We've increased survival rates from illnesses that used to kill people, but with that we see a lot more chronic illness. And an example is prematurity. In the past, preterm babies didn't survive. Now they do, but many of them will have chronic illnesses that need to be managed. And just biotechnology and genetics continues to push medical knowledge forward. So here's a question. What do you think has had the biggest impact on improving childhood mortality and morbidity? Vaccines, sanitation and hygiene, technology, improved education, nutrition? Which of those do you think? And the answer is A and B. All of them have been good, but the two big advancements for child health have been the widespread use of vaccines and improved sanitation, particularly water, having a safe water supply. So there are national and international organizations that are working to protect the rights of child, and their focus is violence and abuse, child labor, children being forced into military service, juvenile justice, immigrants and orphan children, and abandoned and homeless children. In the U.S., we've developed this measurement of health status that began in '79 with the Surgeon General's report of healthy people. And that gave agenda for public health, what the focus would be. So we had national objectives and we had metrics to be able to measure those objectives. And that gets revised every 10 years. We're currently in Healthy People 2020. And with that Healthy People, the focus really has been on prevention and eliminating disparities. We know certain ethnic groups, certain socioeconomic groups just don't have as good of health outcomes. And so we're trying to prevent illness and eliminate differences between different groups. Infant and neonatal mortality. So infancy is the first year of life. Neonatal is the first month of life. You can see we have really declined on infant and neonatal mortality over the decades. However, among developed countries, we're pretty much the highest compared to the other developed countries. So we do have some work still to do. I would say that's not entirely fair, though, because we have a lot of babies born with congenital or defects and anomalies that in other countries are aborted and are not born. So as far as morbidity, what brings kids to the hospital? Well, in that up to 4 age, you can see respiratory illnesses are the big thing, and you'll see that at Valley Children's. As they get a little older, it's still a lot of respiratory illnesses, but other things as well. And then when we get to the teens, we have a lot of teen pregnancy, bringing the teens in for pregnancy and childbirth. So what about mortality? What do children die of? Between 0 and 1, the big thing is congenital abnormalities, followed by premature birth or sudden infant death syndrome. Once you get over a year, between 1 and 4, the leading cause of death is accidents. Between 5 and 9, the leading cause of death is accidents. Between 10 and 14, the leading cause of death is accidents. Between 15 and 19, the leading cause of death is accidents. So, what causes all these accidents? Motor vehicle crashes. And that can be as a passenger in the car. Your teens, it may be as a driver in the car. It can be as a pedestrian being hit by a car, or a kid on a bike being hit by a car, but it somehow involves motor vehicles, the majority of those. So, that brings us to car safety. We want children in a 5-point rear-facing car seat in the center back seat until they're 2 years of age, or if they surpass the weight limit for that car seat, then it can be turned around, but preferably keeping them in the back seat, rear-facing, till 2 years of age. So pediatric nursing. The philosophy of pediatric nursing is to promote or assist the child to maintain optimal health. There are 2 big key concepts in pediatric nursing. The first one is family-centered care. If we have a child in the hospital and there are siblings home who are stressed, they are going to make the parent stressed, who is going to make the child stressed, and now we've just slowed down their recovery. So getting an iPad so the child can FaceTime with the siblings is part of a nursing intervention. That's not just extra. That is expected. And we need to make sure as we're doing these family-centered interventions that they're culturally appropriate for the family. The second big concept is atraumatic care. We are going to do everything we can to minimize both the physical and psychological stress of the entire family. This doesn't mean the child will never have pain, but we're going to pick the least painful method, both physical pain and psychologically. And then, like other nursing, we want everything we do to be evidence-based. Research shows this is the best choice, not just our opinion. So, the role of the nurse in relation to morbidity and mortality in children is that we do a lot of education. Let's teach families about child safety and think about the child's age developmentally. What are they doing? What safety do we need to teach? Let's teach about vaccinations. There's a lot of bad information out there. Let's encourage preventative care. If a child comes in for a well visit, something may be caught early before it's a big problem that's hard to care for. And teaching families when they should go to the hospital. Any infant under 3 months with a fever should go straight to the emergency department. A few hours can make the difference in the outcome. So any infant under 3 months with a fever, straight to the emergency department. And our goal is to prevent unnecessary death and illness. So the scope of pediatric nursing, just like other nursing, it's to use that nursing process, to do a good assessment, make a nursing diagnosis based on what we find, make a plan with outcomes that we want to reach, implement our plan, and then evaluate, did we reach those outcomes or not, or do we need to change our plan? Our standards of professional practice are to provide quality care, to be a professional and practice evaluating. Did we do things the right way? To always stay current, maintain that continuing education. To be collegial and collaborative. We're going to work with the other healthcare providers, but we're going to do it collegially. To be ethical in all our treatment of our families. To use research and evidence-based practice as we make those interventions. To be a leader promoting child health and an advocate for our children and our families. So some of the core principles of ethical nursing are autonomy. Families get to make the choice even if it's not the one you would want. Beneficence. Everything you do should be beneficial. Non-malfeasance. Cause no harm. Justice. Act fairly. Veracity. Tell the truth. Don't lie to your families. And fidelity. Keep promises, which includes maintaining confidentiality. Informed consent. When we have a consent signed in pediatrics, it's usually going to be the parent. However, there are some exceptions. If you have an emancipated minor, they will sign for themselves. That means they're married, they're in the military, or they've had a child, so they're parenting. There are rare exceptions when they're financially independent of their parents and are considered emancipated as well. Some key things we need to think about, though, is who does sign if there's a divorce. Is there one parent who legally signs? Do they both need to sign? Foster parents. Sometimes the foster parent signs. Sometimes the foster parent is not the legal person for signing consents, even though that's who the child's living with. In pediatrics, we want children to give assent, which means they're not signing the legal form, but they're agreeing that they know what's going to happen and they're agreeing to it. So, things we need to consider: if the child doesn't live with a parent, if they have a foster parent, who's the signature after a divorce, and then an exception is psychiatric and reproductive health. Children over, I believe it's 14, do not need a parent's permission, and in fact it's illegal for us to tell the parent that they've sought care. So we're going to follow HIPAA, just like with adults. Don't share your computer logons. Turn off the computer when you leave. Make sure you're not leaving child information about patients where anyone can see it. That includes computer and written papers. Make sure if you're sending an email or just talking that there are no patient identifiers in that. And then at Valley Children's, no phones in patient care areas. It's too easy for somebody to think you took a picture of something or recorded something on your phone. So if you need to answer a phone, you need to step out of the patient care area first. Exceptions to confidentiality is if there's a suspicion of abuse or neglect, and we're supposed to make a phone call as soon as possible and follow it with a written report. Certain infectious diseases must be reported to the health department. And then if there's the concern that someone is going to be harmed, either harm themselves or harm another, then we no longer follow confidentiality. Now we're a mandated reporter and we report those things.